What I'd like to project to the community here is that I believe we physicians have taken away the autonomy of patients who are pregnant with opioid use disorder.
Welcome to Intrinsically Motivated, where we're having conversations with experts in the field of addiction, recovery, and those who've been affected by it as we seek to mobilize the church to replace addiction and mental health challenges with flourishing. On this episode, we're going to talk to Dr. Martin Olsen. He's a professor of obstetrics and gynecology at East Tennessee State University. We'll be discussing the prevalence and effects of neonatal abstinence syndrome, its economic impact, as well as his unique approach to treatment. I'm Tanner Clements, and I'm the Media and Training Director for Uplift Appalachia. Prior to what we're eventually going to end up talking about, which is going to be, MAT treatment, medication-assisted treatment, and recovery and that sort of thing, I want to talk about how you got into obstetrics and gynecology. What was it that originally kind of drew you to that field?
Well, I actually did a family medicine residency before I did my obstetrics and gynecology residency, and that specialty was just too broad for me. I wanted to be really good at something, and I felt really good at the care of pregnant women. So I did a second residency in Chattanooga, and that was very fulfilling. I moved from Ohio to Chattanooga, loved Tennessee, and when this job came open in the early 90s, it was starting a residency program was sort of what was going on with the East Tennessee State University College of Medicine at that time. And so it was very exciting to move from Chattanooga to here and be a part of that. And I've been here 30 years now. Yeah,
so did you think you wanted to teach at the beginning, or was that just...
I had an outstanding teaching mentor. His name was John Dacus, and I would not be in academics without him.
So I guess, what kind of work do you do now? Who is it that you're working with, that you find yourself primarily working with now?
So I'm a professor of obstetrics and gynecology at East Tennessee State University, and I see patients only outpatient. And so we have 2 half days a week where I see pregnant patients or recently postpartum patients with opioid use disorder. The other time I teach residents or see patients in the private office.
Right. So I guess, obviously, opioid use disorder has become a huge deal and a huge focus of what you're doing. So how did that transition happen? Obviously, when you started, you didn't necessarily think, I'm going to this and I'm going to be doing a lot of work with opioid use disorder and moms and that sort of thing. So was it a slow transition? Did you see it coming at any point? Or was it like all of a sudden you realized, wait a second, this is just all that I'm seeing
Actually, that's that second part. It was the early 2000s that we started noticing there's the occasional patient. And then the late 2000s, 2008, it's like, where did all these we called it opioid addiction at that time, where did all these opioid addicted patients come from? It's just, where did they come from? And then a colleague of mine who's now retired said, well, patients would like help with this. And the standard of care at that time, which it's still the same standard of care 15 years later, is that when a patient walks in your office with opioid use disorder, you're supposed to say to her, well, what's your dose of Suboxone or Subutex? And let's just keep you on that. And the patient says, well, I don't want my baby to have this drug withdrawal, this Neonatal Abstinence Syndrome. The answer is, that's too dangerous for you. You need to stay on it. So that's the standard of care 15 years ago, 50 years ago, and today. And some patients said, well, I don't believe you. I'm going to do it myself. And they came off on their own or lowered their dose, and we noticed that, and we said, well, look at this. They did just fine. And then colleagues in Knoxville, Tennessee did some research, some of it on jail prisoners who didn't have access to buprenorphine, and they said, well, look at this, the neonatal abstinence syndrome rate. And again, that's the disease babies have when they withdraw from opioids after they're born. It's also called neonatal opioid withdrawal syndrome. And we noticed that the rates were 0 if the patient came off completely, as compared to the national average is 52% for all patients, babies who are on buprenorphine. And so there's a concept in medicine called autonomy, and that's where the patient gets a chance to make their own decisions. So the argument I'd like to project to the community here is that I believe we physicians have taken away the autonomy of patients who are pregnant with opioid use disorder. We tell them the standard of care is, I'm sorry, it's too dangerous. And to me, that's incredibly paternalistic. So there's a concept called treat addiction like all the other diseases. Well, I agree with that. I just don't think we're doing it. Because every other disease, we say, Okay, here are the risks, here are the benefits. What do you think is best for you and your family? Seizure disorder. The risk of changing the patient's seizure medicines is that she's going to have seizures, she's going to have status epilepticus, she could die. Very, very low risk. It's not zero. We have that conversation where we say seizure medication causes birth defects. Would you like to change your medication? Would you like to reduce it to one dose? Would you like to have the lowest effective dose? She says yes or no. But that's not what we're doing for opioid use disorder. And on the side of there was somebody in here from the American Society of Addiction Medicine that felt like arguing with me. What that person would say is, oh no, there's no long-term effects from the use of buprenorphine with pregnancy. And to me, that's just, it's biased assimilation of the data would be the medical term. And with biased assimilation of the data, you believe what you want to believe and you ignore what says is contrary to what you believe. Right. So babies who are born to mothers with high doses of buprenorphine have smaller heads. This is not rocket science. I mean, most of us would want our family members' babies to have a normal head, not a small head. Well, it turns out that small heads are associated with decreased school performance, and it turns out that there's literature going back to the 1980s that says that babies who are exposed to opioids have less school productivity. So I don't think our community recognizes that 10% of pregnant women in our region are on buprenorphine.
Right.
So if you see a pregnant woman walking down the street in Johnson City, Tennessee, or Kingsport, Tennessee, or Bristol, Tennessee, 10% chance that she is on buprenorphine.
Right. So where did that standard of care come from originally? Was there a particular set of research that said this is the best way to handle it? Or I guess where did that original, this is the way we should be treating patients that have opioid use
Well,
disorder?
I think we'd have to go back to the 1970s. And in the 1970s, actually the standard of care was take everybody off. And then a few number of papers, but from prominent individuals, said, no, that's wrong. We should leave the patients on the same dose. And so then the predominant thinking has been, well, let's just leave patients on the same dose. So let's talk about why that is.
You're setting me up perfect. I don't even know why I'm here. You know where we're going. So,
all right.
so why is that?
Well, let's step back.
Yeah.
Let's step back and ask the question, how did we get an opioid epidemic?
Right.
And we got this epidemic because doctors wrote for too many opioids. Well, why did doctors write for too many opioids? Well, they thought it was safe. Because they had Purdue Pharmacy out there saying, oh, it's safe, OxyContin's safe. They had the Joint Commission of Hospitals saying, well, pain is the fifth vital sign. We need to make sure your patients don't have pain. I mean, I remember as a young physician in the early 90s getting pulled aside by an administrator, your patients are in too much pain, Dr. Olsen. You need to write for more pain medicine. Anybody that's listening that goes to the hospital today, they're going to see these frowny faces and smiley faces talking about the pain level. That comes from that era. No patient should have pain. Write for plenty of opioids. And then, by around in the early 2000s, we figured out, well, that was wrong. Well, my version is we're just making the same mistake now that we made in the 1990s. It's a different drug. So my version is that if you have the right amount of opioids, you have a treatment for pain and suffering. If you have too many opioids, you have an opioid epidemic. And my parallel version is if you have the right amount of buprenorphine, which is also described as Suboxone or Subutex, if you have the right amount, you are treating opioid use disorder. If you have too much, you have an neonatal abstinence syndrome epidemic. And we have done a paper that was in the Southern Medical Journal about a year ago. And the paper showed that the more buprenorphine in a community, the higher the NAS rate is. And it just, 2008 to 2018 was roughly the time period studied. The amount of buprenorphine in southern Appalachia quintupled over that time period, 5 times as much. The NAS rate went up by 4 times as much. So it's parallel. And of course, another person might say, well, yeah, that's sad, but look at all the lives we're saving. Well, unfortunately, the opioid death rate from overdose also rose during that time period. My version is that wouldn't it be nice if there was a pill that just take care of everything? But there's not.
There's not, right? Yeah.
There's not. And
we're always treating whatever the next symptom is.
Yes.
And it's like you said with people trying to say your patients have too much pain. We're still just trying to avoid pain now, just a different type of pain from a different type of cause, that sort of thing as well. So you obviously have gotten to publish some stuff on. Have you had any pushback against the things published, or as you have tried to kind of share your thoughts on that, have you met with any
Yes, I was set to present at the American College of OBGYN in 2021. 3 days before my presentation, I was called and told my presentation was inappropriate.
What was inappropriate about your presentation, do you think?
Well, they wouldn't want to give me any details.
Right. So have you continued to see some resistance to, or I guess, let me ask this a different way. Let's go slightly different. So how are you practicing now? Are you able to give your patients that autonomy back as best you can, or is there a way for you to kind of?
Let me explain our program.
Yeah.
And this gives me an opportunity to thank my boss, Dr. Fuchs, my department chair, for his support, and my dean, Dr. Bill Block, for his support, because they've been very, very supportive of taking care of patients and patient rights and patient autonomy. So let's get in the shoes of a young woman, and let's say that she fractured a pelvis, and she had significant pain, and she got narcotics to treat her pain, and after a couple of months, the doctor said, well, you're addicted now, and I'm not treating your pain anymore. I can't write for this anymore. You're addicted. And so then she went to the ER, and they said, you're an addict. Get out of my ER. And then she went to whatever she had to do to get her fix. So she might have to steal. She might have to prostitute herself. Whatever was necessary, she decided that this is what I got to do because I can't cope with these withdrawal symptoms. Well, then she goes to a medication-assisted treatment clinic, and if she picked a good one, she's going to have comprehensive care. She's going to have psychologic care. She's going to have a social worker that helps with her get a job. She takes buprenorphine, also called Suboxone, also called Subutex, and she can now live with her family again. She can now hold down a job. She can be a mother to her kids if she's got them, and life is dramatically improved. She is far better off than when she was at risk of a fentanyl overdose and death. So this can be a life-saving medication. My point is I think we would just bite for too high a dose. But getting back to this patient, so she comes, so now she's pregnant, and she says, well, I have drug withdrawal. I don't want it to have Neonatal Abstinence Syndrome. So she comes to our office. She's told that, well, here's the risks, here's the benefits. If you think you'd like to stay on the same dose you're on, we'll support that. If you think you'd like to lower your dose to the best of your ability, and we have a unique philosophy, which I call lowest effective dose. So there is a 2 milligram buprenorphine pill. Somebody at the Food and Drug Administration says 2 milligrams works, so they wouldn't have a 2 milligram pill. And they actually have lower doses, but those lower doses are hard to find, so we tend to stick with the 2 milligram pill because our patient can actually access it. So at 16 milligrams, we say to the patient, well, your first taper is to 8 milligrams, and 4 weeks later, your next taper is to 6 milligrams, and 4 weeks later, your next taper is to 4 milligrams, and then 2. And then at 2 milligrams, we say to the patient, how are you doing? Is this the best you can do? Because if it is, you're doing better than 97, 98% of the women in America. You should be proud of yourself. And if you want to keep going, then we'll keep going. And most patients do not want to keep going. They say, I'm stable here. I'm not going to relapse. I think this is what's good for me. Maybe someday I'll come off, but I'm gonna stick with 2 milligrams. Another group of patients says, no, I do want to come off. So then, and that's like 10% of our patients. It's a very low number. So then the next taper is to 5 or half of a pill, which is a 1 milligram dose. The next taper is to 0.5 or half a milligram dose, and then off. And again, the Neonatal Abstinence Syndrome rate is 0 if the patient is off. It is 7% at 2 milligrams based on our presentation, which we did present at an ACOG meeting as an abstract. And it is 52% with standard care. So the teaching that's out there now by the experts is that, well, it doesn't make a difference if you taper. And they just didn't taper down the proper dose. They tapered down to 15 milligrams. We're tapering down to 2.
So now when a mom has her baby, do most of your patients then stay at that 2 milligrams? Do they go back up to where they were before? Do they continue? Do they find some medium spot in between? What does that look like?
It's variable, and this is back to patient autonomy. What does the patient feel is best for herself and her family? So most of them do stay at the same dose. Some of them say, well, I'm stressed. I'm worried I might relapse. I think I need to go up. And we'll go. We're not going to go all the way up to 16 milligrams because the patient's symptoms have been effectively controlled on 2. We might be at risk of diversion, so if we go too high. But if the patient wants to go back up, that's not a problem. I've had patients that hold the baby in their arms and say, I don't want this stuff in my baby's life. I quit now. And others will taper over the course of the next year. We will follow a patient for a year because we want to make sure that the transition is orderly.
Right, yeah.
And then with about a year or so, we'll then transition the patient to one of the local providers.
Nice.
Now, this is a time for me to talk about how potent this drug is. And so it's 30 morphine equivalents. So what a morphine equivalent is a measurement used to describe the potency of a drug. So Lortab, hydrocodone is something that some of our listeners might be familiar with. They may have taken after surgery. That's 1 morphine equivalent. Oxycontin is 1.5 morphine equivalents, and buprenorphine is 30. So when a patient is on the recommended dose, and get on the website, that's the recommended dose is 16 milligrams. That's the same as 480 morphine equivalents or 48 Lortab 10s a day. So when I've had, if you go back 6 years, when patients were still accessing pain pills, they'd come in on 6 Oxycontin 10s or 90 morphine equivalents. They'd be seen by somebody else in town to put them on 16. So they went from 90 morphine equivalents to 480 morphine equivalents. As opposed
seems like we're going the wrong direction there.
Right. So again, the standard care in the United States is 16 milligrams. You need MAT, stay on it.
Where did we pick that number? 16.
My best guess is that the manufacturer was involved in that process.
They said we can make one that's a 16 milligram pill, and that'll be great.
Well, in Tennessee, it's currently TennCare is not paying for more than 2 pills or 16 milligrams. Go across the state line to Virginia, they pay for 3 pills, 24 milligrams. And so a expert physician explained to me how most of her pregnant patients are on 24 milligrams because that's the highest dose the state will allow her to prescribe.
And has that 16 milligrams changed over time? Has that increased over time, or has that been the standard for?
That's what's on the manufacturer's website is the target dose.
Okay. And so and your language you said was minimum effective
effective dose.
Okay. And your target for that is 2
milligrams
based on, again, just the availability.
Well, 2 milligrams is a number that when we look at our own patients, the abstinence rate is 7%. So it seems like that's a dramatic improvement over 52.
Absolutely. Well, I'm trying to do that math in my head. If 16 milligrams is 490 or whatever you said, or 480.
Yes.
Then 2's quite a lot less than that.
Well, it's 60.
That's still relatively That's still a relatively high number for somebody who maybe has never used anything like that. That would be still a very high dosage, I would imagine.
Yes.
Somebody has not built up any tolerance to anything like that. So you've got that 7% number. Have you gotten to present that 7% number? Kind of what's been kind of the response from the community or the scientific community to hearing how this has been effective in that way?
Well, it's kind of fascinating to talk to anybody that's not involved in addiction. It's, wow, this is great. We can do something. We can improve care. But when you talk to folks that are in the world of addiction, not all, but a significant number, and I would say certainly ones in leadership positions, the answer is, well, that's not how we do things. And they are legitimately worried about relapse, overdose, and death. And it's the relapse, overdose, and death of a pregnant woman or a young mother would be a horrible thing.
Right.
Now, we have to contrast that with the knowledge that addiction is associated with relapse, period. So for listeners out there, if you've got a family member that you're suffering with, for that family member to have 10 or 20 relapses, that's probably normal.
Right.
So I would say that I agree that relapse, overdose, death is a horrible thing. But just the mere factor of relapse to say, well, we can't do it because they might relapse when we know that to some level, these folks relapse. That is just part of the disease.
Right.
You have to ask the right question. Does the patient who is using the lowest effective dose relapse at a higher rate than the patient who is on 16 milligrams? Well,
right. And that was about to be my next question.
Yes.
Have you seen any significant difference in that?
So it's our belief that our relapse rate is the same or lower than the high dose. And part of the reason for that is that there are counterfeit medications out there that are actually fentanyl. So, and this includes Subutex. So I've had patients describe needing Narcan because they took some medicine that they thought was Subutex, but it must have been fentanyl because they need Narcan to recover. And so when you've got people that are out there in an economy of, well, I'm going to buy some medicine and then when I get mine, I'm going to sell mine, then they're more likely to get into some fentanyl. So there's no evidence, in my view, to support a conclusion that patients being treated with lowest effective dose methodology are at higher risk of relapse than anybody else. They're all at risk of relapse, in my opinion.
So if anything, it's even, but at the same time, they may be in a better place because they went that direction.
Well, these are very highly motivated patients.
Right.
So about 45% of patients in our practice say, yes, I'd like to lower my dose. And 55% say, no, I'm good, don't want to do it. I'm not in a place in my life where I can do that. So my version would be that I personally do not think that a patient who's on Suboxone today is committed to being on that the rest of her life. Now, you can find lots of people that argue with me. They're going to say, no, once you're on it, you need one the rest of your life. And my argument is, yeah, that does make a lot of money for the manufacturer.
Right.
And patients have been coming off opioids for 2,000 years. So we need to figure out how to do this safely.
Right.
And then if the patient wants to come off, well, why wouldn't you pick the most motivated time of her life to help her do that?
Yeah. Yeah.
So if the answer is you can't come off while you're pregnant, then I think what you're saying is you can't come off.
In general. Right.
Yeah.
Yeah. So I'm just curious if you've observed difference in quality of life in general for patients that have maybe tried coming down on reducing their dosage versus staying there. Does it look different in their family life or anything like that? Do they have any improved relationships or anything? Because I think one of the things that I hear you talk about is you have a very motivated individual that's motivated to try to, and I would wonder if there's any correlation between that same motivation that's motivating them to try, stepping down their dosage and also having improvements in other areas of their life as well.
So I was at a banquet a couple of weeks ago, and the server came up to me and she says, well, Dr. Olsen, I don't know if you remember me, but I've been off for 4 years now. And she pulled out pictures of her baby, and I complimented her, and she was just so proud of herself. So my version is when you see somebody at 36 weeks gestation skipping out the door because they're so proud of themselves, I've seen that.
Right.
That to me says you're doing something to help this person's self-esteem. So what patients will tell me when they say, when I came off, I just felt better. I felt like myself again. Because again, this is a drug that has sedating effects. And so when a person is on it the rest, for however long, yes, their risk of relapse on street fentanyl is reduced, but that doesn't mean that they're maintaining it in a normal fashion. And so they just generally feel better. Now, part of the disease is that there are increased risks of domestic violence, and there's poverty associated with it. So that's getting back to, wouldn't it be nice if a pill would fix everything, but we know it won't. So our program is comprehensive. We have a psychologist. We have 2 case managers. One of them is paid for via ETSU, and one of them is paid for via Neonatal Health. We've got a nursing team that's very, very engaged. The front desk folks know that these are folks that require a little extra time, so they give it. So it's a whole team effort, and not every patient gets where we hope they would get. But most of them do. Once they've made the commitment, most of them do. At least they get a healthy baby. And I'm not my job is not to cure addiction for these patients. My job is to give them a healthy baby.
Right. But along the way, you've seen some benefits in that as well.
Yes. If they decide that's where they want to go, that's their decision. That's their autonomy.
Yeah. Our kind of mentality as Uplift Appalachia is we don't want to say that the public health model's not effective in keeping people alive, but we think that there's something beyond just like not dying. We actually want to help people flourish. And so some of what you're describing is if you see somebody skipping out the door, that's even a step above where they could have been had they just kind of stayed in the system that they were in the rest of their lives. And so that's kind of the difference that we're hoping to see made in lots of people's lives. It's not just being alive, but it's actually being able to live beyond that.
And when I see the patients skipping out the door, I mean, I'm very proud of the fact that 400 babies don't have shrunken brains, or at least their brains are less shrunken.
Yeah.
Because of the work that I've done here in Johnson City. But there's, what about the other hundreds of thousands?
Right. So are there any other programs like yours in the country right now that are doing similar?
The one in Knoxville had a senior leader, and it stopped doing that. And there are others, but we're the only ones really writing about it. So there are certainly some private docs that are saying, this is a problem in my community, I'm going to address it. And if the patient wants to do this work, and the folks in Greenville come to mind as an example of supporting patients that want to decrease their dependency during pregnancy.
Yeah. So is there a coalition of people out there that are trying to make a little bit of noise and say this is something we should consider as an alternative? Or?
No, we haven't really been able to get together as a coalition. There are other folks doing this type of work.
Right.
I mean, the University of Kentucky recently put out a paper where they they sort of started like we did a few years ago, of saying, well, if that's what you want to do, then okay.
We're not going to stop you, but we're also not going to...
Which is better than stopping
Which is better than stopping, yeah.
And then they wrote their results that said, well, look at this. The Neonatal Abstinence Syndrome rate is lower.
So I guess, what are you hoping to be the next steps kind of in this practice? Are you hopeful for anything that's to come? Are you seeing any movement in a positive direction with this sort of thing? Or?
Well, I would like to point out that I'm in our region of So I'm going to discuss now state of Tennessee data with you. So in our region, which includes Washington County, includes a 6-county area, but interestingly, only 3 hospitals that deliver babies in this 6-county area. And our program started in 2016. And when we started our program, other MAT providers in the community said, well, if they're doing it and that's what our patients want, then shouldn't we do it too? And my answer is good for you. And in these 3 hospitals, all patients have access to doctors that would say, well, if that's what you want to do, then more power to you. And our NAS rate has dropped by 50% between 2017 and 2016 and 2021.
That seems like a huge number.
That's state of Tennessee data.
Yeah.
Compared to Sullivan County, where it's roughly the same as it was. Now, so I have begun pointing this out to state officials, but my version would be that, again, state of Tennessee data, every NAS baby costs $46,000 more than the usual care. So why don't we take that money, put it in the front end, and we don't have to spend any extra dollars to improve outcome. The money's already in the system. We'll just spend it on the front end to help folks lower their dose and then have less bills for neonatal abstinence syndrome. So that is what wonderful thing could happen in the future. That's what I would hope that our state would get. Our state has
been interested in that sort of thing? Or are you getting anywhere with that?
I haven't got anywhere yet.
Not yet.
But I'm tenacious. So.
Right. Yeah. So just thinking about the numbers of cases that we're seeing, if this were to be implemented all throughout Appalachia, I would think this could become a huge number, right?
Yeah, for the United States, it's 30 to 40,000 babies per year have neonatal abstinence syndrome. And of course, that other 48% of babies that don't have neonatal abstinence syndrome still are at risk for failure to thrive and smaller brain size and things like that.
Right.
So we're talking the potential to affect, if half the patients would like this, then we can affect at least 30,000 babies in the United States per year.
And that's generational impact over time. That's the thing, is it compounds.
If you don't mind, I'd like to really emphasize that.
Yeah.
Because a baby born today with a brain that is smaller than its genetic potential has the chance of not doing well in school, therefore not graduating from high school, therefore more likely to go to jail, therefore more likely to not have a job. I mean, it's an 80-year problem, and we as a society are sitting here doing the same thing we've been doing 50 years with a large population, perhaps 10% of our children at risk for school failure.
And that same cycle just continues to perpetuate itself, because that now leads to more people that have neonatal abstinence syndrome down the line, and again and again and again, and if something doesn't change. Is there anything that I haven't asked you about that you think that you think is helpful for people to know about kind of this world? Well,
I don't know that people understand the economics of Suboxone and Subutex in our region.
I would love to hear your perspective on that.
So first, Suboxone is buprenorphine plus naloxone, and Subutex is buprenorphine alone. And so the reason there's 2 formulations is that buprenorphine plus naloxone, or Suboxone, is less likely to be diverted. So for diversion purposes, if a person were to take some Suboxone and they had some fentanyl on board, they might be thrown into a provoked acute withdrawal, especially if they inject it. Subutex, they might have withdrawal, but it wouldn't be as bad. So if you are a person that says, well, today I can get some fentanyl and tomorrow I can get some meth and the next day I can get some Suboxone, you're not going to do as well if the next day you can get some Subutex. So in our current values on the street for an 8 milligram pill of Suboxone is about $40, and for Subutex it's about $60. So in Johnson City, Tennessee, there are 14 MAT clinics, medication-assisted treatment clinics, which I'll call MAT from here on. At present, the last time I checked, 7 were cash only, and the cash only clinics charge about $150 a week. So I have this little drill I do with the medical students, but I'll be nice to you. So I say, pull out your cell phone and get out your calculator. And 275 is the number that used to be the cap on how many patients you could see at a time. There's now no cap, but for fun, we stick with 275.
Right.
And then we multiply that by $150, and we say, and then the person gets 48 weeks a year to work because they're going to take a month vacation, and 48 times 275 times $150 is $1.9 million. So this is, to step aside, there are MAT providers in Johnson City I would be thrilled to send my family member to because they care about the patients. They're good. If I could wave my magic wand and get rid of these cash-only clinics, I would do that. because what causes NAS? Well, it's buprenorphine. It's not fentanyl. When you pull the state of Tennessee data, 2/3 of it is buprenorphine. And then there's a category called non-prescribed drugs. Well, that's buprenorphine too. So in our area, 90% of NAS is or more is buprenorphine. So that's what causes it. And doctors are writing for buprenorphine. So to me, to have an economy where the doctor says, and I'm going to quote a medical student saying this is what an MAT doctor said to the medical student. I wasn't there, but the doctor is writing for 16 milligrams or 2 8-milligram pills and says to the student, now I know she only needs 8 milligrams, but they can sell one and take one, and then they'll have money to come and see me next week. If you were to do a literature review on diversion, you would find a whole list of articles that say diversion is good. Because what about all these people that can't access treatment?
Now people are getting all these life-saving
Now
medications.
they can get this.
Right.
And of course, we've discussed the fact that it wouldn't be nice if a pill fixed
Right.
everything, but it doesn't. You need the whole program of psychological help and social work help.
You need that whole wraparound care.
So what this is actually doing, in my view, is keeping people from getting the care that they need, recognizing that in Tennessee, with its lack of TennCare eligibility for some patients, that the street, this is the only way they can access the medication is by selling some and taking some. That's a part of our healthcare system that I wish we could fix. But my version would be that, gee, I've got some Lortab at home left over from my surgery. If I sell it to you because you got pain, aren't I doing a public good the same way that somebody's selling this other controlled substance? I mean, that's, of course, a ludicrous thought, but they're both controlled substances. And to say one's okay to sell on the street and one's not, to me, is completely ridiculous. So I would like the listeners to know that there's a buprenorphine economy, that buprenorphine diversion is common. I mean, the medical students tell me they're taught that you can't abuse buprenorphine. Well, patients smoke it, they snort it, they inject it, and they stick it in their rectum. They're not doing that to self-medicate their symptoms. They're doing it because of its effect. And so buprenorphine, my version is it's a gateway drug. I've had patients tell me that was the first drug they ever took other than marijuana. And then they moved on to fentanyl or meth or whatever. But that was, it comes from a doctor's office, or at least they think it does if it's not counterfeit. And so therefore they think it's safe. And then it becomes the first stepping stone to addiction in other areas. The second that I'd like to make sure folks know about is how fentanyl works.
Yeah.
So fentanyl is, the ingredients are made in China, and then they're shipped to Mexico where they're compounded into fentanyl, and then they're slipped across the border to a local manufacturer who has a pill press who then makes medication that looks just like the real thing, but it's counterfeit. So I had a patient bring in a counterfeit Oxycontin pill and show it to me. I couldn't have told the difference, but we knew her from her drug test that she had fentanyl on board and not Oxycontin, so fentanyl was what was in it. And so a patient doesn't know, they think they're taking a legitimate medicine, but they're taking something that's actually fentanyl. And the challenge of this illicit manufacturing is there's no quality control. So the same blender that you and I might use to make a smoothie is used to make pharmaceutical pills. So the right half of the pill doesn't have anything in it. The left half of the pill has enough to kill you.
Right.
And so there are fentanyl strips that test the medication to make sure it's not fentanyl. So, and that's better than not testing the medication.
Right.
But still, you could have a concentration of the drug in the part of the pill you didn't test, so that's not foolproof.
It's wild.
Yes, it is.
Wild.
Well, and death rates are going up because of fentanyl. And now we've got, and every so often there's new drugs. Xylazine is out there as an animal sedative, and it's we don't have a drug test for that.
Yeah. And all of this, kind of going back to what you're talking about, is because people are trying to find that magic pill that just makes everything feel okay, and there's not one that we have. So what's next for you? What are you hoping? What's the next opportunity that you have to kind of talk about this or publish this, or do you have anything?
Well, we've got some papers in progress, and so we'll hope that they'll be accepted. So.
Yeah. And I guess what's kind of your take home, if you were to summarize everything that somebody who's hearing this whole conversation?
Well, we can do better. And so my version about management of addiction, like all the other diseases, is I agree, but I don't think we're doing it. And so if a person from the American Society of Addiction Medicine was sitting here, that person might well say, well, diabetes, you need insulin the rest of your life. Hypertension, you need antihypertensive the rest of your life. And my answer was, well, people do change. So if you're 300 pounds and you lose 100 pounds, maybe you don't need insulin anymore. Maybe you don't need your antihypertensive anymore. And if you're in a place in your life where you can manage your recovery, maybe you don't need Suboxone and Subutex anymore if you got the right people around you. So let's do treat it like all the other diseases, but that does not mean staying with the rest of your life. I'd like for the folks out there to recognize that have family members that are struggling with opioid use disorder, methamphetamine use disorder, that relapse is common, and they should just, it's not a personal affront when your loved one relapses. That's just part of the disease. You just have to sort of recognize that's part of the disease, and you hope over time the relapses get further and further apart. But have your Narcan around, because relapse can be associated with death. And I mean, we can do better. I guess that is the bottom line. And one of the key elements is to stop the stigma. So when I've walked in to give discussions and public talks, and I've said, well, raise your hand if somebody you know or love has struggled with substance use disorder. And usually about half the people raise their hand. And I'm actually kind of convinced that half of the other half just are uncomfortable raising their hand. Not ready to
raise their hand yet.
Yeah, so I think the reality is, if you just are willing to open your mouth and talk about it, you're going to find that 1 out of 2 of the people standing next to you says, well, yeah, I've got that same problem too. So let's get rid of the stigma. Let's treat it like other diseases. And let's, as a community, recognize the fact that we can do things about this. We can do things to make it better.
Right, we can do something better. And I think it sounds like that's where you're taking it from in this one area. We're looking at it more from the how can we also help provide, like you said. I think one of the things that you said that sounded the most like a lot of what we want to say is like, all of your staff know we're all here to try to help these people that are struggling in a very specific way. They may need more time at the front desk. All of that, I think, is a really important thing to say. It's like, it's an all hands on deck sort of thing. Yes, you may be the doctor that's helping talk about how much medication they should be, but the whole team is also there to kind of help support them and walk with them through that. And I think we're trying to do that from kind of the church side, is try to say, we're trying to be one more tool in the toolkit for people that are trying to find whatever flourishing is going to look like for them. And we're not trying to replace the medical community. We're not trying to replace medication or whatever different way that people are trying to find recovery, but we're trying to be that just one more element that's in that kind of, I guess you could say, recovery ecosystem. We're trying to be that one piece that maybe has not taken as active a role as we could from the faith community side, and say, we're just trying to be that next piece that's there to help support people through whatever the steps are that are, like you said, working best for them, so that we can help them be as successful as they can be. And
yeah, it's my hope if any doctors are listening to this, especially primary care doctors, they'll decide to take on the challenge. I mean, if you make the diagnosis of opioid use disorder, then treat it like you do all the other diseases. And there's 14 buprenorphine clinics in Johnson City. Well, that would be an opportunity for primary care doctors to step up. It is not easy because of the bureaucratic snafus associated with it. So you have to accept the fact that there is going to need to be more time commitment.
Next time on Intrinsically Motivated.
Like, I'm a real ass human. I've got dreams. I've got hopes. I've got aspirations. I've got kids. I mean, like, dude, not death is not, like, that's not success.
Intrinsically Motivated is an Uplift Appalachia podcast. Uplift Appalachia seeks to replace addiction and mental health challenges with flourishing. And we believe that an intrinsically motivated church is the answer. To learn more, visit upliftappalachia.org.